it. So a very warm welcome to all of you to this 194th edition. A very important topic. ICD-11 is here. So how to go about it? What is the transition? So the host has muted everyone. The panelists can unmute themselves. The meeting will be recorded and put on the YouTube platform for later viewing. Questions are invited in the chat box. The chairpersons, the moderators can take it up to the resource person. So next slide, please. Handing over the session to Tofan Pati sir. Sir is the chairman of this program. Sir, I'm not reading your slides, so please return the favor. Over to you.
Thank you. Thank you, Dr. Ali, for not reading my slide. Please glass over. I have to formally introduce our vibrant chairpersons, Dr. Alim Siddiqui, Treasurer of IPS, Dr. Amrit Patadosi in absence, Secretary of IPS, and Dr. Next slide, please. Next, Dr. Bisal Chabra. He is currently the HOD and Senior Consultant, Fortis Hospital. He is our most extremely vibrant moderator. Next one, please. I have to introduce the chairpersons, Dr. Ravindra Vinoli, Additional Professor of Psychiatry, Kasturba Medical College, Manipal Academy of Higher Education, Manipal, Udupi. MD at KMC Manipal, post-MD worked in various capacities of matter since 2012. 40 index publications and 5 book chapters and 90 newspaper articles. First person to start telepsychiatry in Karnataka from KMC Manipal. Awards from State and Press Institute of India. Currently Associate Editor of Journal of Psychiatry Spectrum. Dr. Abhidhan Manoli, welcome. Next slide, please. Next, Dr. Jitendra Jinger from Udaipur is Professor and Head of Department of Psychiatry at Gitanjali Medical College and Hospital, Udaipur. Currently General Secretary of IPS Rajasthan branch, Treasurer of IPS North Zone. Total teaching experience of 16 years. Qualified up to North Zone India in Young Psychiatrist Scholarship Award in 2008. Winner of Galat Award, Shulanki Award, Dr. A.K. Kala Award, and Professorship Gautam Morrison Award in 2019. Publications, 20 publications, national and international journals. Organizing Secretary of 6 conferences and workshops. Completed advanced course in medical education conducted by MCI. Invited as guest speaker in various workshops, seminars, and conferences. Welcome, Dr. Jinger. And from here onwards, I hand over the team to the chairpersons, Dr. Jinger and Dr. Monoli. Please take over. One has to introduce the speaker, the other one has to introduce the topic. I think Dr. Jinger will introduce the speaker.
I will introduce the topic, yes.
Okay. Dr. Monoli introduce the speaker.
Sir, I will introduce, sir.
It is
Thank you.
From
Thank
now
you,
onwards, the meeting is yours.
Yes, sir. Thank you, sir. Thank you, sir, for that generous introduction of us. Also, I would like to thank Thursday Musing for giving us this opportunity. This is probably the second time that I am here. Previously, I was a speaker. I thank Alim sir, Amrit sir, and dear Vishal sir also. Okay, so I will quickly introduce today's speaker, Dr. Dinakaran Damodaran. Dr. Dinakaran did MBBS from Government Stanley Medical College, Chennai. He had completed MD Psychiatry from NIMHANS, Bangalore with a gold medal. He is currently working as an assistant professor of psychiatry at NIMHANS. Dr. Dinakaran's research interests include biological psychiatry, trauma, resilience, and brain stimulation. Dr. Dinakaran had published more than 50 research papers and 20 book chapters. He is co-investigator in the Tamil Nadu Police Wellbeing Program, Karnataka Telemanas project. With this quick introduction, now I request my co-chairperson, Dr. Jitendra Jinger, to introduce about the topic. Over to you, sir.
Thank you, Dr. Ravindra. Once again, I would like to pay my regards and thanks to the Thursday Musing for this opportunity. The topic you all know that the ICD-11. The ICD is a globally used diagnostic tool for the epidemiology, health management, clinical purposes which is managed by WHO with main aim of comparing the statistics, find out the causes of mortality and morbidity between the various parts of the world. The main highlights of the ICD-11 is involvement of digital innovation, supplementary section for the functioning assessment, and adding of dimension approach like severity of illness, course of illness, onset of symptoms or the disease disorders, and timeline of the diagnosis. For the detailed presentation, we have learned speaker with us, Dr. Dinakaran Damodaran from Bengaluru. I request him to please start his presentation. Over to you, sir.
Hello, good evening, everyone. Hope my screen is visible.
Yes.
Right. Is it moving?
Yes, sir.
Moving,
Right.
quite perfect.
Right. Okay. So, today's topic is going to be on ICD-11 and whether is it the right time to transition from ICD-10 to 11 in our country. At the outset, I would like to acknowledge the Indian Psychiatric Society, especially the Odisha chapter, for bringing up this Thursday Musings lecture series that has been going on for some time. I acknowledge the chairman, moderators, and the chairpersons who have agreed to preside over this lecture session today. I do not have any conflict of interest, and my presentation over the next 35 to 40 minutes is going to be completely based on two books. One is ICD-10 CDDG. What is that? We will see, and ICD-11 CDDR. So these are the two books I am going to refer to throughout my presentation. I have not taken any other material from any existing scientific articles. So the outline of my presentation would be to see what is the purpose of ICD-11, to give an overview about how ICD-11 is developed, and the crux of the session would be on the changes from ICD-10 to ICD-11. We will go through as a walk down through the ICD-11 different chapters and its organization and how they are coded, and whether ICD-11 is useful for research, and maybe what are the advantages of ICD-11. Also here, I would like to highlight that tearing apart ICD-11 is not the agenda of the program today. Critically analyzing ICD-11 may be taken for some other session if the time permits, but today we will be focusing only on these things. So what is the purpose of ICD-11 or any other diagnostic classificatory system? Why should we have them? This is mainly for systematic recording and reporting of the morbidity and mortality index of different disorders, not just mental disorders, from infection to neoplasm to nervous system disorder, circulatory system disorder, including mental, behavioral, and neurodevelopmental disorder. We may have to systematically record these illnesses and report these illnesses to WHO. That is the primary purpose, and to analyze how these disorders manifest, interpret the different patterns through which these illnesses manifest, and compare globally on the different levels of prevalence of each of these disorders. Mainly, it serves the purpose of being a common language across space and time. Space here refers to different parts of the world, and time here refers to if somebody is diagnosed to have depressive disorder now, 5 years down the line, we may see that the person had a depressive episode and may be having different manifestation, but it serves the common language between clinicians and between different governments to help identify and categorize these disorders. So how will it be useful for policymakers? So to understand the impact of mental disorders on the public health system, and once they understand this is the level of morbidity, this is the mortality associated with these illnesses, they may allocate resources, human resources, as well as financial resources to help mitigate the impact of these disorders. We are all service providers, clinicians. How is this ICD-11 going to be helpful for us? So it helps predominantly in clinical recording of disorders for day-to-day use, and it may inform treatment of choice for a particular disorder. And once we know a clear pattern of how the disorder's course manifest, we may be able to take measures to prevent it at the earliest development. So how is this ICD-11 developed? Does it come out of sky, or is there a different process that goes into the development of any diagnostic classificatory system for that matter? So what happens is there is a international collaborative working force that is organized to develop ICD-11, and each one is given specific role for a particular disorder or a particular group of disorders. So that group works on those disorders. They review the existing evidence for the presence of that disorder. They also review the current scientific understanding of that disorder. And through expert consultation, there is a lot of back and forth that happens between service providers. Also, the service user's perspective is taken, whether it is reflecting what they are going through. And a beta version is usually released, which goes into field trial. It happens for multiple years, and then the final version is released. So, for example, for this ICD-11 to happen, we know that ICD-10 was approved in 1990 and it came to practice in 1992. 15 years later, in 2007, WHO organized a working group to revise. So it was the effort started in 2007. By 2015, we had the first version of ICD-11, which went into a lot of field trials. And in 2019, it was accepted by the UN Assembly, World Health Assembly, to adopt ICD-11. And it was decided that ICD-11 will come into practice on 1st January 2022. And by now this year, specifically with respect to mental disorders, because ICD-11 is for all disorders, not just mental disorders, but the ICD-11 CDDR book has been released in 2024, which describes mental, behavioral, and neurodevelopmental disorders. So what goes into the process of developing this classificatory system is to improve the validity of the disorders that are being studied. What is validity here? Which means the diagnostic criteria should measure what it is supposed to measure. So if we say psychosis, whether it is actually picking up psychosis in the community. So usually there will be a lot of addition, deletion, and threshold discussions that will go on, whether 2 weeks have to be kept or a month has to be kept, or how many symptoms has to be there to call something as a disorder. Such deliberations go on to improve the validity of that particular category. Followed by, there are two more important aspects of developing any classificatory system. One is the clinical utility and the global applicability. The clinical utility here refers to whether the particular category improve the communication between different clinicians, and whether the category has a goodness of fit, which means that it describes in detail about a phenomenon or a syndrome, and whether the description is not too elaborate, but it is also feasible with the time constraints and the human resource constraints. Global applicability is taken into consideration here. And also the clinical utility also is informed by how much does this category help me or any other clinician to choose an intervention for that particular disorder. So these are the different factors that are taken into consideration in developing ICD-11. So coming to the definition of mental or behavioral or neurodevelopmental disorder, what is the definition ICD-11 gives us? Mental, behavioral, or neurodevelopmental disorders are syndromes. Earlier in ICD-10, they were called as disorders. But right now, the concept has changed towards syndromes, which means syndrome is nothing but a group of symptoms or signs which occur more frequently for a particular disorder. So disorder is not actually an exact term. It may mean different things to different people. But right now, the concept is these are basically clinical syndromes that have significant disturbances in the individual's thought, emotion, or behavior. And this new line is added to the definition, which is it reflects a dysfunction in the psychological, biological, or developmental process. And it is usually associated with the impairment in personal, family, social, educational, occupational, or other functioning. So if you see the three different dimensions of the definition, which states that it is a syndrome, which means a group of symptoms and signs occurring together related to a person's thought, emotion, or behavior, and it has a predisposing factor, which is dysfunction in that person's psychological, biological, or developmental process. These symptoms are happening only because there is some dysfunction in that person's different domain, and it usually has some consequences in terms of distress or impairment in personal, family, or social and different domains. So there is an antecedent, there is a group of symptoms, and that symptom cause significant distress. All three together, the new definition is formed, and it is in line with DSM-5 definition. Earlier, this reflecting dysfunction of psychological, biological, or developmental process was not there in ICD-10. So what we have to remember about ICD-11 is it is not the full assessment. Here in ICD-11, the focus is on classification of disorders rather than completely assessing and inform or telling about how the treatment should go. And ICD-11 provides for flexibility to exercise clinical judgment. So the clinician is given free hand or a flexible hand to take into account the personal, social, cultural, and health system factors that are relevant to the client who is sitting opposite to him during the consultation, and then come to a diagnosis. So it just helps in categorizing the problem rather than being the whole standalone full assessment by itself. So these two are the books I have referred to. So one is ICD-10, the earlier book. As you say, the name suggests it's a classification of mental and behavioral disorder. Now the name has changed to mental, behavioral, and neurodevelopmental disorder. Earlier, it was CDDG, which is clinical descriptions and diagnostic guidelines. Right now, it is CDDR, which means clinical descriptions and diagnostic requirements. These are not guidelines anymore. These are specific requirements that has to be present in a person to call that as a disorder. What are these requirements? We will be seeing one by one. So broadly, what are the changes that has happened? ICD-10, we will go from how ICD-10 was and how ICD-11 now is. Earlier, it was in the 5th chapter. Mental and behavioral disorders were in the 5th chapter, and it was coded by the alphabet letter F. And right now, it is in the 6th chapter, chapter 6. And earlier, the sections were 00, F00 to F99. Right now, the sections are broadly A to E, A, B, C, D, E, and followed by there are numerics, A1, A2, A3, and it goes on. So the first category in ICD-10 was organic syndromes as well as delirium, dementia. Now they have moved to neurocognitive disorders that comes late in ICD-11 because ICD-11 follows a lifespan approach, which means starting with the childhood onset or neurodevelopmental disorder and going through dementia that will come in the last. So F10 used to be substance use disorder, F20 used to be psychosis, schizophrenia, F30 used to be mood disorder. The groupings are same, but their orders are slightly changed in ICD-11. F40 was neurosis, stress-related, and somatoform disorder. Now that one category has been split into 5 distinct groups: anxiety group, OCD group, dissociation group, bodily distress group, and trauma, which is PTSD group. So the one group F40 has been split into 5 distinct groups. F50 had sleep disturbances, insomnia related problems, sexual problem, and eating related things. And F60 had gender dysphoria along with personality disorder and habit impulse control disorder and other paraphilias. Now, sleep and sleep-wake disorder has been separately moved out of mental and behavioral disorders to a separate chapter, and sexual dysfunction related problems are moved to another chapter that would deal on sexual health. And F70 was mental retardation. Now it has come to the front as neurodevelopmental disorder. Similarly, F80, which had psychological developmental disorders, and F90, which had emotion and behavioral disorders that had specific onset in childhood, has been brought to the front as neurodevelopmental disorders. So as I said, sleep has been taken out of mental and behavioral disorder. They have said that it has been taken out not to say that psychiatrist has not been managing it very well. It is to show that there is nothing called as organic sleep problem or non-organic sleep problem. Earlier, we had only non-organic sleep problem diagnosed under mental disorders. Now they are all clubbed together as the same sleep-wake disorders. And chapter 8 deals with neurological disorder. If you see, tics and Tourette syndrome that was there part of the childhood disorders, they have been shifted to neurological disorders. And another Landau-Kleffner syndrome, which is acquired aphasia with epilepsy, again has been moved from childhood onset disorders to neurological disorders. And in disorders, chapter 16, disorders of genitourinary system, we have premenstrual dysphoric disorder that has been secondary parented in our mental disorders. And chapter 17 deals with earlier what used to have hypoactive sexual desire or premature ejaculation or gender dysphoria related conditions are all shifted to chapter 17. And chapter 21 has specific definitions on what is a symptom, what is a sign, what are on different clinical findings. Say, for example, it would go on defining what is formal thought disorder, etc. We will see it down the line. And chapter 22 deals with injury, poisoning, and external causes. And chapter 24 specifically, which used to be the Z category in ICD-10, it is covered under chapter 24. It is very important because they are not clinical syndromes or disorders, but they definitely produce significant distress in individual, which makes them come in contact with the health service. For example, people who may call telemanus, they may not have specific mental disorder. They may have exam-related anxiety. They may have relationship-related difficulties, divorce-related problems, which is not amounting to a depressive or anxiety disorder, but these are the factors that are making them come in contact with health service. So they are classified under factors influencing health status. Similarly, we have harmful substance use in a substance use category, in addiction disorders category, but there is something called as hazardous substance use where it has not reached the level of harmful use, but the person is exhibiting certain characteristics which may predispose the person to have harmful use later. So the person may be prevented instead of from hazardous use to harmful use. Similarly, acute stress reaction was there in ICD-10 under stress trauma related disorder, but now it has been moved from the mental health spectrum to the distress spectrum. So what has changed other than this is, see, the common criticism about ICD-10 or 11, it is being very categorical. That is yes or no. And it is not being actually showing the dimensional nature of many of the psychiatric disorder, which is many normal individuals may also have obsessive symptoms, but why we call someone as OCD and someone as having only transient obsessive symptoms are not being very well captured is the one of the common criticism. ICD-10 was mostly categorical, except for, if you remember, mental retardation was specified as mild MR, moderate MR, severe MR. Similarly, depressive episode was categorized or specified as mild depressive episode, moderate depressive episode, and severe depressive episode, which are dimensional in nature. So ICD-11 again is more categorical, but there are multiple attempts made to make it little more dimensional. Specifically, the 2 disorders in ICD-10 were extended to have 5 disorders. For example, here, intellectual development, depression, bodily distress disorder, personality disorders, and dementia can be specified as mild, moderate, and severe. And there are multiple other specifiers that are there. Let us see what are these specifiers. So course can be specified as first episode, or there is an episodic pattern. Either psychosis or substance use can be coded as first use or episodic use or continuous use. Onset, early onset, late onset, and specifically if there are mood and psychotic disorders that have onset in the first 6 weeks after delivery, it can be specified as puerperium onset. And severity, I have told you, mild, moderate, and severe. And symptoms, psychotic symptoms can be specified to have positive, negative, motor, cognitive. And mood symptoms, we'll see what are the different specifiers that are there when we go to mood disorder. Remission, again, you can specify whether the syndrome is in symptomatic phase or in partial remission or full remission. Specifically in anorexia nervosa, they have given this specifier called improving, where the anorexia nervosa person is in going towards remission, and their body weight is improving can be specified. And insight specifically with OC spectrum disorder can be specified as good, fair, poor, and absent. In substance use, intoxication state can be specified as mild, moderate, and severe. Withdrawal can have different manifestation from seizure, hallucination, or both. Psychosis, mood, or substance-induced psychosis, mood, anxiety disorder can be specified. And personality traits can be specified: anancastic, dissocial, negative affectivity, detachment, or borderline. The different domains can be specified in that particular individual, and more than one domain can be specified in any given individual. Gaming and gambling disorder can be specified to be online or offline. And more importantly, earlier we used to write the diagnosis as provisional in ICD-10. Now, in ICD-11, you can code that as well, that diagnosis is provisional or diagnosis, there are differential diagnoses that you are considering. So the coding structure has little changed in ICD-11. Say, for example, in ICD-10, F20.00 is schizophrenia, paranoid subtype, and it is continuous course. But in ICD-11, there are two things called as, one is called pre-coordination and other is called post-coordination. So pre-coordination means each code has 6 digits, 6A20.00. These are the 6 digits. So 4 digit before the decimal point, 2 digit after the decimal point. Here it states that what is 6A20.00 means: schizophrenia, first episode, and symptomatic status. So there is something called as post-coordination. That is, after the 6 digit is over, you can keep on adding different codes for that specific individual. Say, for example, if you add 6A25.0, which means that the same as above, schizophrenia, first episode, symptomatic, but what is that symptom is the person has more positive symptoms. Then you can also add saying that whether that positive symptom is how severe. So the positive symptoms are moderately severe. And then you can add similarly for different symptom dimension. Say, for example, you can add cognition 6A25.5 and XS25, which means that cognitive symptoms are severe. So this is an individual who has a schizophrenia diagnosis with positive symptoms which are moderate in severity and cognitive symptoms which are very severe in nature. So it will help us to guide the treatment decisions better. So it may be very confusing for the beginner, but you are not going to memorize any of this because ICD-11 is in completely digital format. You just need to see it online and you can download and keep it offline as well. So the coding becomes very easy. You need not remember or memorize any code, but you should know what disorder can be coded in which way so that it will help future research. So let us walk down ICD-11. Let us see what are the different things that are there in ICD-11 chapter by chapter. So if someone wants to ask what is the take-home message of this presentation, this slide would be the take-home message, which is the major improvement in ICD-11 compared to ICD-10 is it follows a uniform structure on the information, which is it is similar to DSM-5. So every diagnosis starts with essential or required feature. That is why this book is called ICD-11 CDDR, diagnostic requirements. So that individual has to fulfill all the criteria of the essential features, or there would be specified some number of symptoms would be specified. At least so many symptoms has to be definitely present in the individual, and that is called as essential feature. There may be additional clinical features. Say, for example, craving was one of the feature in ICD-10. Right now, craving for substance use is taken away from essential feature and kept it as an additional feature. So craving is no more required for diagnosing somebody. It may be helping us as an additional feature, but for essential feature, the person should have use despite harm, salience, or especially the loss of control, tolerance, and withdrawal. Out of these group of symptoms, the person should have certain number of symptoms to qualify dependence. So craving has become an additional feature, which is no more required for the diagnosis. And this another thing is, as I told before, what is normal, what is disorder, that boundary is given for each disorder. It may be from depression, grief, substance use, what is normality, and how as a clinician we should take a decision that this is not a normal manifestation, this is actually a disorder. And course features are given, which means how does a disease evolve, how does it manifest first, what are the different changes that you want to expect, and then how does it progress, whether it remits on its own. All these are given in the course features. And developmental presentation, how depression may be different in children, how depression may be different in adolescents, how it can manifest in adults. Say, for example, ADHD, what features may be common in children, in adult, what features may be more common. Such things are given in developmental presentation. Culture related factors, because each country has a way of, in each country, people have different way of expressing mental distress. So that features are taken into account in ICD-11. And gender related, sex related differences, how common is it in women, how common is it in men, those things are covered in sex and gender related features, and what symptoms may be predominant. For example, suicidality or the symptom severity may be different in genders. So those things are covered in sex and gender related features. So also it is followed by how this disorder is different from other closely resembling disorder. For example, there may be a lot of confusion about what is complex PTSD and how is it different from borderline personality disorder. We will see about that when we discuss the PTSD group of illnesses. So coming to the first category, as the coding starts, it starts with 6A, which is the A is, it will go, earlier we used to have F1 or F0012. Right now, 6 is the chapter number. A is the first illness. A00 is the first section, and 00 is the starting of the illness, which starts with intellectual developmental disorders. And it is followed by speech language disorder. So if you see, it goes from A01, 02, and once it reaches 6A9, it will automatically, the next disorder will become 6B. So we should not see it as different section. We should see it as a continuous process of 6A to 6E that is being defined in ICD-11. So the first group contains intellectual developmental problems and speech and language disorder, autism spectrum disorder, developmental learning disorder, motor coordination disorder, ADHD, stereotype movement disorder, other specified and unspecified disorder. So what is different than in ICD-10 is, here just the IQ is not given more importance. Both intellectual functioning as well as the adaptive functioning are taken into account. For example, in situations where neuropsychological assessment or IQ assessment is not possible, they have given wonderful tables on what are the behavioral indicators that the clinician should see in a child when IQ assessment is not possible. Say, for example, a child with mild intellectual disability, what are the features to expect? So such behavioral indicators are given in detail in different tables that would help someone to identify without even going into IQ assessment. So that flexibility is given in ICD-11, that even without IQ assessment, you can go ahead and diagnose mild, moderate, and severe intellectual disability. Autism spectrum disorder, again, is specified in different way, whether the child has proper intellectual development, how is the functional language development, or is there any loss of previously acquired skill. So such things are specified in autism spectrum disorder. In ADHD, there is no symptom counting. Say, for example, there should be 2 hyperactivity symptoms. There should be 2 inattention symptoms. Such counting of symptoms are not followed across ICD-11. Yes, maybe for few disorders, not for all disorders. The flexibility is given in clinician's hand. So that symptom counting threshold is taken out. And as I said before, tics and Tourette syndrome and Landa-Kleffner syndrome, which used to be in childhood onset disorders, has been taken to neurological disorders in chapter 8. So coming to the next part, if you could see, 6A is only continuing and it becomes 6A2. 6A2 is the schizophrenia and other primary psychotic disorders. As the grouping is, it is similar to our ICD-10, old ICD-10, schizophrenia, schizoaffective disorder, schizotypal disorder, acute and transient psychotic disorder. In both schizophrenia and ATPD, the subtypes have been removed. There is no paranoid or catatonic or undifferentiated types anymore. It's just schizophrenia. And we used to have catatonic schizophrenia as a separate subtype of schizophrenia, but right now catatonia is given a separate category between psychosis and mood disorder, given that both spectrum can produce with respect to mental disorders, can produce catatonic picture. And so as I said before, positive symptoms, negative symptoms, cognitive symptoms can all be rated as mild, moderate, severe. And for this, there is a scale given within ICD-11. What is mild cognitive syndrome in schizophrenia? What is mild positive symptoms? What is moderate negative symptoms? Everything anchor points are given within ICD-11. And acute and transient psychosis also has an episodic course. I mean, you can specify that there is episodic course of that the person is having multiple time points in his life, had only acute psychosis, that is as present acute onset with polymorphic picture, and it remits on its own. After some years or some months in between, it again comes, but again remits. If somebody has such a picture, episodic course can be specified. Coming to bipolar disorder, this everybody might have been aware now that bipolar type 2 is added, where one hypomanic episode and one depressive episode are mandatory for the presence of bipolar 2 disorder. And another new thing is, earlier, if there was psychotic symptoms, the episode automatically becomes severe depressive episode. But right now, in ICD-11, you can code moderate depressive episode with psychotic symptoms or without psychotic symptoms. And you can, as I said before, the mood episode can be specified to have more anxiety symptoms, panic attack. Earlier, we used to call something as chronic depression. So you can code it as persistent depression. Earlier, we used to call somatic syndrome. Now you can specify it as melancholic, and whether it is seasonal onset or is it rapid cycling, those all things can be specified. So it gives a better dimensional view of how the depression is in that particular individual. And earlier, mixed depressive anxiety disorder was part of adjustment disorder. Now it is moved from anxiety disorder to depression. It is to follow the same as DSM-5. And 6E20 is nothing but if there is a puerperium onset. Any of this disorder is present during the first or has an onset during the first 6 weeks after delivery, you can code it as puerperium onset with or without psychotic symptoms. And as I said before, there is premenstrual dysphoric disorder, which is coded in chapter 16 of genitourinary system, but it is secondary parented here in this group, so that if a woman during majority of their menstrual cycle in the last 1 year has a specific set of features during which has an onset in the premenstrual phase and gets better after menstrual, when the period starts, it is coded as premenstrual dysphoric disorder, and it is being included. Coming to anxiety, as I said before, neurosis has been split into 5 different domains. First is anxiety and fear related disorder. The categories remain the same: generalized anxiety disorder, panic disorder, agoraphobia, specific phobia, social anxiety disorder. Separation anxiety disorder and selective mutism, which was there in childhood onset, has been, for the phenomenological perspective, has been kept along with the anxiety spectrum. And all these disorder can be specified with whether these disorders has panic attack or not. GAD with panic attack, GAD without panic attack, agoraphobia with or without, specific phobia with or without, social anxiety with or without panic attacks can be specified. So second in the neurotic spectrum is the obsessive compulsive and related disorders. So here, as we are specifying panic in the anxiety spectrum, here we are specifying insight for all this. Whether the insight is good, fair, or poor to absent is being specified, and it is pre-coordinated, which means 6B 20.0 something is good insight and 20 point something is poor insight, like that. So it is pre-coded. Within the 6 digit of the code, it is coded. And body dysmorphic disorder was not separate earlier. It was part of hypochondriasis, and hypochondriasis was not part of obsessive compulsive spectrum. It was part of somatoform spectrum in ICD-10. Now it has been brought under obsessive compulsive spectrum. Trichotillomania was part of impulse control habit or impulse related disorder in ICD-10. it is again brought because they all share the same phenomenological features. They are all brought together. Tourette syndrome is secondary parented. If you see the code of Tourette syndrome, it is 8A, which means it is a neurological disorder, but you can code even in mental disorders, but the code that you should use is of neurological disorder. So coming to the third domain, it is the disorder specifically associated with stress. Here, post-traumatic stress disorder. And by now, everybody will know that a new diagnostic entity called as complex PTSD was introduced in ICD-11. So here, the cultural context is given significant importance in this group of disorder because a trauma can manifest in an individual in a different way based on which country they are from and which culture they are from. Say, for example, in our country, the PTSD prevalence is less than 0.2%, according to the last National Mental Health Survey, whereas in Western countries, it is usually around 5 to 6%. Why is there such a difference? Are our people experiencing trauma in a different way, or are they manifesting trauma in a different way? So all these are given importance in the cultural context of this disorder. And as I said before, each disorder will have course of the disorder. So in that, it is given that at least 50% of the individual with PTSD, they have a self-limiting course, which means after a trauma, they develop PTSD, you diagnose PTSD without any intervention. 3 months later, at least 50% of them have their symptoms go away. So it has a very self-limiting course. On the other hand, complex PTSD do not have a self-limiting course, but for the diagnosis of complex PTSD, the trauma should be prolonged or the trauma should be repetitive in nature. For example, in repeated child sex abuse or domestic violence where there is continuous trauma. So that is one difference. And the 3 symptoms of PTSD should be there, which is re-experiencing like flashback, avoidance, or the hyper-arousal state should be there, along with 3 other symptoms that has to be there in complex PTSD are there should be negative view about self, negative view about interpersonal relationships, and there is a negative emotional state. The affective regulation is poor. So all these 3 plus the 3 PTSD symptoms should be present to diagnose somebody as complex PTSD. Prolonged grief disorder was earlier not there. It was part of adjustment disorder. Right now, it has been given a separate diagnostic category. As I said before, acute stress reaction has been removed from this group and has been put in the distress group and the Z category or the chapter 24 right now. So other reactive attachment disorder or part of childhood disorder has been brought here because they all share the similar phenomenological features. Fourth domain is dissociative disorder. Here, earlier there used to be different types of conversion, non-epileptic status or non-epileptic disorder. Right now, it is given a simple name, dissociative neurological symptom disorder, and that specific symptom can be coded, which is whether the person has auditory disturbances, visual disturbances, motor disturbances, or seizure, or cognitive disturbances can be coded here. Dissociative amnesia can be coded with or without few. And earlier we had only one category, trance and possession disorder. Now possession has been given a separate entity where the person behaves that they are possessed either by a ghost or a deity, and it is seen as unwanted by the person themselves or by the culturally it is not accepted by the society. It is given a possession trance disorder. So there is another disorder that is added is partial dissociative identity disorder. Here again, there should be 2 personalities that should be present within the individual, but one personality is usually dominant and other personality is seen as intrusive, and the discussion between these 2 personalities are usually not observable. But in dissociative identity disorder, you can see 2 personalities. Here, the discussion goes inside, but the person feels that there is another personality that is trying to intrude into their personality. So coming to feeding disorder, the significant change here is for anorexia nervosa, you have to specify body weight. Earlier, the BMI was 17.5. Now it is revised to 18.5 kilogram per meter square. And it can be specified. If the BMI is between 14 to 18.5, it is called as significantly low body weight. If it is less than 14, it is called as dangerously low body weight. And as I said before, the person can be improving because of the treatment, and that also can be codified. Binge eating disorder was not there earlier. It has been added now. So avoidant restrictive food intake disorder means that the person do not have the overvalued idea of thinness, but they are for some reason restricting either the quantity or the variety of food, and that leads to distress and problems with the individual's functioning, and it is called avoidant restrictive food intake disorder. And eliminate after feeding disorders, we have elimination disorders. Here, enuresis can be coded as nocturnal enuresis, or it is in the daytime or in the night time, and or it is present in the both time. And encopresis again can be with constipation, with overflow incontinence, or without constipation and overflow incontinence. And bodily distress disorder like mental retardation and depressive disorder can be specified as mild bodily distress disorder, moderate or severe. And a new category of body integrity dysphoria has been added, where a person feels that they should not have a particular body part. It is not BDD, but the person has an inherent wish that they don't have their right hand or they don't have their right leg, and they may involve in certain behaviors to harm themselves, and it's called as body integrity dysphoria. So coming to the substance use disorder, see, as we had seen in ICD-11, sleep-wake disorder has gone out, and sexual-related dysfunction and other gender-related disorders had gone out of mental and behavioral disorders. Similarly, with the ever-expanding substance use pattern, we may see this entire spectrum going out of ICD-12 if it is going to happen in another few years. So, because it is expanding, and if you see, there are 14 different categories of substance that are listed. There are dependents defined for different substances, but there is no dependence on caffeine. Caffeine can produce harmful use. Caffeine can produce intoxication. Caffeine can produce withdrawal symptoms. Caffeine can produce induced anxiety disorder, but caffeine cannot produce dependence according to ICD-11. It was there in the beta version. Caffeine dependence was there, but somehow, due to maybe two reasons, they have removed. One is the loss of control on caffeine use was not established during the field trials. Another explanation they provide is along with the behavioral symptoms for any addiction, it also should release a lot of dopamine in the substance should be able to release a lot of dopamine in the ventral striatum. Caffeine is primarily an adenosine receptor antagonist, and it releases dopamine in a minimal way or in a very less way, and it just produces alertness more than high. That may be the reason that they are not thinking of caffeine as a dependence producing substance. And earlier, there was a separate category of non-psychoactive substances. They are not supposed to produce dependence, but people abuse them, like stimulants or antidepressants or even analgesics, antihistaminics. They also can be coded along with the other substance use disorder in this ICD-11. So earlier, harmful use in ICD-10 was defined as harm to self only, which is the person is getting some physical or psychological harm because of using a substance. In ICD-11, one more thing is added is if that harmful use, it is considered harmful if it has led to physical or psychological harm in other people, then also you can code it as harmful substance use. As I said before, substance dependence, caffeine is excluded. In substance withdrawal, so all these categories, all different substances are there. For example, harmful use, harmful pattern of use, single episode harmful use, harmful pattern of use, substance dependence, substance intoxication. In substance withdrawal, hallucinogenic drugs and dissociative drugs like ketamine or PCP are not known to produce withdrawal symptoms. So you cannot quote them to say that they have withdrawal symptoms. Induced delirium, psychosis, mood disorder, anxiety disorder, OCD, impulse control disorder. So there are different substances that can produce this disorder. Caffeine and nicotine cannot induce any of these disorder, except caffeine can induce anxiety disorder, but caffeine cannot induce psychosis, mood, or OCD related disorder. Nicotine cannot induce any of these disorders that we commonly see in clinical practice. And impulse control disorder, only a few drugs are given. So, and also the non-substance related behavioral addiction are also added here. Earlier, pathological gambling was part of habit related disorder. Now it is included in the substance related disorder. And the gaming disorder is a new category that has been added, and it can be predominantly online or offline gaming that can be diagnosed. So coming to impulse control disorder, these two new or slight changes in the disorder is compulsive sexual behavior disorder is the only sexual related disorder that is there in the mental and behavioral spectrum. Rest all the disorders had gone to sexual health related chapter 17. In chapter 6, there is only one this disorder because it shares the phenomenology with the impulse control, where a person has repeated urge to or repeated desire to involve in sexual behavior and thus involved in behavior, and it leads to distress in the individual. It's called as compulsive sexual behavior disorder. And intermittent explosive disorder, where there are episodes of verbal or physical aggression, and mainly these two says there is loss of control over one's behavior. And oppositional defiant disorder can be specified to have chronic irritability, anger, along with whether the person or the child or an adult has limited pro-social emotions or have typical pro-social emotions can be specified. Similarly, conduct disorder can be specified as childhood onset or adolescent onset. Personality disorder had undergone a drastic change. You can diagnose personality disorder based on two things. If the person has different self-related beliefs and interpersonal problems for a prolonged period of time, you can diagnose the person to have personality disorder. The earlier grouping of cluster A, cluster B, cluster C has gone. And right now, the grouping is based on the severity, mild, moderate, and severe, as well as you can specify which domain of the personality is more involved in that person, whether it is negative affect, detachment, dissocial, disinhibition, anancassia, or borderline. All this can be specified, and one person can have multiple domains specified, so that can be done. And if the person has a difficulty, they are not coming similar to hazardous substance use. If a person has difficulty, that also can be codified in chapter 24 called as personality difficulty. So coming to paraphilic disorders, earlier whatever was there is retained. One that is added is other paraphilic disorder involving solitary behavior or consenting individual. All the above disorders are of non-consenting, that is done with people without their consent. But certain paraphilic disorders like consensual sadism can be done between two individuals and both of them consent. So that also has been included. And certain paraphilic disorders may involve without other person, like asphyxiating oneself to get a sexual high can happen without involving other people. That can be coded in solitary behavior. And factitious disorder, either it is imposed on self or the Munchausen's by proxy, which was there earlier, codified as factitious disorder imposed on other people. So coming to the last part, which is the neurocognitive disorders. So if you see the diagnosis, simply it's not going somewhere. See, it is paraphilic disorder is also codified 6D, and factitious disorder is also codified 6D, and neurocognitive disorder is also codified 6D. So it's not following a very specific pattern, but it is just continuous 3, 4, 5, 6, 7. And once it reaches 9, it will automatically go to 6E. That is the pattern that has been followed continuously in ICD-11. So delirium, as suggested, it can be because of different conditions that are coded elsewhere, maybe medical condition, or it can be because of substances. All that can be coded in detail. Mild neurocognitive disorder was there in ICD-10, and it is retained and it is given a separate category in ICD-11. Amnestic disorder, specifically with what is that amnesia, you can code, whether it is retrograde amnesia, anterograde amnesia, or whether it is transient global amnesia, or it is confabulation related. All these can be codified using symptoms that are there in chapter 21. You need not go to that chapter. In the ICD-11 book, all these symptoms are given at the end of the book, so that you can refer to the symptom and then code them when you are diagnosing amnestic disorder. And in Alzheimer's dementia, as I said before, mild, moderate severity can be coded, and specific symptoms can be coded, and it is followed by vascular dementia, Lewy body dementia, frontotemporal dementia, dementia due to psychoactive substances, including medication, and dementia due to Parkinson's, Huntington, exposure to heavy metal, HIV. All these can be coded if they are due to that certain other medical conditions or psychoactive substance. What is the symptom that you can specify in Alzheimer's is whether the Alzheimer's dementia patient or other dementia individual with other dementias, whether they are exhibiting psychotic symptoms, whether they are exhibiting mood symptoms, anxiety symptoms, or is apathy more pronounced, or is there agitation, disinhibition, wandering. All these can be coded specifically in dementia. So this will be the extra or the secondary symptoms. One is this is related to the puerperium onset. 6E20 means there is a mental and behavioral disorder, but it has its onset in the puerperium, which is defined as the first 6 weeks post-delivery with psychotic symptoms or without psychotic symptoms. And 6E40 is there is a physical health problem, but there are mental health symptoms, syndromes, or personality disorder which is worsening that physical problem. Say, for example, a person has gastritis, they have anxiety, that anxiety is worsening that gastritis. So it is a reverse causation. One mental health problem is worsening the physical health problem, can be coded as 6E40. And it was there earlier as well as different number, but right now it has given much predominance. And the secondary, which is because of other medical condition, a person is having mental health problem. So here, for every disorder, what are the different medical conditions that can manifest as this disorder is given in a tabular format, which is very helpful. Say, for example, what are the syndromes that can manifest as neurodevelopmental syndrome? What are the medical conditions that can lead to a person to have obsessive compulsive disorder from Huntington's, and different things are given as examples for these conditions as to have a secondary mental health disorder due to medical condition that is coded elsewhere. So as I said before, this is chapter 21. Different symptoms and signs are defined here. I mean, with respect to consciousness, what is stupor, what is coma, the definitions are given here. You need not go to the chapter. As I said before, the symptoms are listed at the end of the book itself. So it may be related to mood, it may be related to form of thought, perceptual disturbances, consciousness disturbances, all the symptoms are given. You just need to read them and see whether that is applicable in the individual and code. And other maltreatment, if somebody has physical abuse, can be coded from the chapter 23. And chapter 24, problems associated with, as I said before, what comes to the primary care or to telemanus, that people do not have disorders, but they definitely have distress due to different reasons. It may be due to war, conflict, or it may be due to interpersonal problems, or it may be due to educational, financial difficulty, uncomplicated bereavement. All these can be coded in earlier it was Z category, now it is chapter 24. So if you see at the end of the book, they themselves have given how ICD-11 and ICD-10 match. Say, for example, single episode of severe depressive episode, moderate with psychotic symptom, has been given an explanation that earlier, if it was there, it would automatically become severe psychotic, severe depressive episode. But right now, you have an option to code it as moderate depressive episode with psychotic symptom. And this crosswalk is given for all disorders at the end of the book. And whether ICD-11 is useful for research. Earlier, ICD-10, there was a separate category called as diagnostic category for research. But the revising team felt that very minimal number of papers had come out of ICD-10 DCR. So they have done to get away from that. Instead, they are planning to release something called as structured clinical interview, which will have specific threshold. Say, for example, there should be 3 panic symptoms. There should be 4 catatonic symptoms. Such threshold is not there in the ICD-11, but for research purpose, to have an uniformity, it may be needed. So they are planning to come with that interview schedule to call SCI, structured clinical interview for ICD-11. And there is flexible interview called as FLIA, FLIA-11, which can be used by lay persons because the questions are very simply posted there. And this is the instrument that our country is going to adapt for National Mental Health Survey 2. So FLY will be used in National Mental Health Survey. We are going to do National Mental Health Survey 2 with ICD-11 diagnostic system. And there is, as before, structured clinical assessment for neuropsychiatry. The 3.0 can be used for clinical diagnosis in tertiary care facilities. So we'll end by saying what are the different advantages of ICD-11. It is the most largest and participative process that has ever gone for classifying mental health disorders. It has definitely better clinical description. For example, old ICD-10 was only 350 pages. ICD-11 is more than 800 pages. So the clinical description of each disorder, along with its cultural features, course features, differential diagnosis, it takes a large volume, and that description will be useful for the clinician to understand the syndrome better. And it improves the flexibility. There is no pressure on duration. It should be for 1 month. Say, for example, generalized anxiety disorder should be for 3 months in ICD-10. That pressure is taken out of ICD-11. It says that the anxiety feature should be present for several months. So such pressure is not there. So it is very flexible and easy to use in clinical setup. Accurate data capture with respect to number of specifiers that can be used, and the structure is consistently followed from first intellectual disorder to the neurocognitive disorder. The structure is followed throughout. And as I said before, cultural and developmental features definitely add to the understanding of the syndromes.
Hello.
हेलो आई थिंक मेरे को लगा मेरा आई थिंक ही इज लॉस्ट द कनेक्शन
Yeah.
Dr. Dinakaran,
Dr. Dinakaran,
yes, sir. Dr. Dinakaran
yeah.
is back.
Dr. Dinakaran, we just lost.
Yeah, some network difficulties. I don't know. Yeah, is the slide visible now?
Yes, sir. Visible, sir. Slides are
Okay. Yeah. So yeah, can I continue? Is it okay?
Yes, sir, please.
Yes, sir.
Yeah. So it has coding for traditional medical diagnosis as well. If somebody was following other systems of diagnosis, that also can be coded. And it has an integrated proposal platform for updation. I mean, you can propose something new if you want to be added or deleted, can be proposed online by any person, and it will be taken for due review. And functioning assessment, as the chairperson was mentioning, the functioning assessment can be done using the WHO DAS scale. And then there are extension codes, as I said before. So it is a revised classification system in digital format. And one thing that ICD-11 makers have very clearly pointed out is it is likely to be the standard for global health information for some time, perhaps as long as or longer than ICD-10. So we may not be able to see a new diagnostic system at least for the next 10 to 20 years. This is going to be the standard global health information. So it is for us to adopt it as early as possible so that we can follow this standard of practice for the next many years. Thank you.
Thank you, sir. Thank you. That means we all have to now move towards it. It is actually the time for transition.
Yes.
Thank you, sir. It was a very focused, all covering, all encompassing, a very wonderful presentation.
Thank you.
So thank you, sir. And now over to chairpersons for their opening remarks. Then we take some questions from the chat box. So Ravindra.
Yes, sir. Actually, we
Yes.
conduct these workshops on ICD-11 for postgraduates. It usually takes 2 to 3 days for us to solve this hands-on workshop. As you mentioned, it was developed based on the field trials and various mental networks which went on for a decade. And most of us were part of the field trials. So we know the process of development, what the steps have been transcribed in the developing these things. The second thing that came up was those who were in the field trials were offered to do a training in ICD-11, where we were given the task of case vignettes were given and reach a diagnosis, and there was to be like, why did you diagnose this? Why not something else? Okay, subsequently, now GCPN, Global Clinical Physician Network, which is there by WHO,
Yes.
it offers free training in ICD-11. Those who are interested can log in, register yourself, and go through all the modules. There are different modules, and you will get a certificate for completing that course that that you have completed ICD-11 completely. Okay, so that is one thing that has happened. So there are a lot of changes that have happened. Versions, as you know, there are 4 versions now: MMS, and for clinic, for clinicians, for research, and there are primary care version also. So interested one can undergo the training and can know things easily. And there was one question that somebody was mentioning that it is very tough for PGs to transit from ICD 10 to 11. But Dr. Dinakaran has mentioned in one slide about how the structure of ICD is there, how it has transition has happened at a basic level. Look at earlier, we didn't have all the like essential features, additional features. We didn't have lifespan perspective. We didn't have cultural perspective. We didn't have gender differences, etc. All these have been included. Rather, it has become more like a theoretical or the chapter wise, where we have a more clear understanding of ICD-11 now. Okay. So some of the things have changed drastically, as you mentioned. Especially, I would like to highlight 2 important things that have happened. In the addiction, as you rightly mentioned, some things have been taken out, but something has been emphasized mainly in all the addiction and related disorders. That is loss of control. That has been highly emphasized in all this. If you look at any impulse control disorder or eating disorder, anything, that is one thing that has changed, loss of control. Major change that has happened was in mood disorder, especially in depression. Depression, we had like 4 features of depression, additional or somatic syndrome, etc.
Yeah.
Now it is cluster wise: affective cluster, vegetative cluster, cognitive behavior cluster. Now, among ICD-11, here they mention that there should be 5 out of 10, okay, and there must be one criteria at least to diagnose depression, right?
Yeah.
Now, something funny that has happened here is what we want in ICD-10 is sad mood is a must thing to diagnose depression, right?
Yeah.
Whereas in ICD-11, we can diagnose depression even without the presence of sad mood or depressed mood, because we need only one criteria from affective cluster where it is depressed mood or anhedonia. The anergia has been lowered down significantly. So now if a person has just anergia plus additional features, still we can diagnose depression. That is a drastic change that has happened in ICD-11. Okay. Then another thing that has happened was something new has been introduced in the depression here in ICD-11. Okay. So we used to hear the term chronic emptiness. It was in borderline personality disorder. Okay. Now that has made entry into depression as an additional feature. So exact elaboration of that emptiness is not there, but that has made an entry into this. Further, sexual anhedonia or decreased libido has been given a higher status now. It has come to the level of depressed mood. Then anhedonia part, there is a sexual anhedonia also has been incorporated in this. Okay, so these are some of the important or major changes that have happened. Other things, as you rightly mentioned, schizophrenia, all varieties have been taken out. There is only one. Now, schizophrenia, you can put separate. Catatonia is a separate diagnostic entity. Okay, eating disorders, there are some other things that have happened. One important diagnosis that crept in here is ARFID, okay, avoidant restrictive food intake disorder.
Yeah.
Now, the person doesn't have any other psychiatric diagnosis, let's say. A request to do a survey or a study specifically in the college age group, 18 to 25 professional college age group student, using this ARFID criteria. You'll get to see that so many people we can diagnose with this, where they don't want to eat, no reason. Okay. So these are some of the things that have transition that have been taken place, and the presentation was good. So now we can go to Dr. Jitendra, or some of your opening remarks before you proceed to other questions.
Yes, sir. Yes, sir. Uh, Thank you, sir, for the informative and the insightful presentation. Now we can move for the question answer session. Hand over to moderator.
Thank you, sir. Thank you, Dr. Ravindra. Very useful snippets you gave. There is a question from Dr. Bakyaraj. If sexual disorders transition from psychiatry, which specialty will address non-organic sexual dysfunctions?
So as such, it has not been moved out of the mental health. It has made into a separate category. Sleep disorder
Okay.
and sexual disorder, it's a separate entity where we can study it, but it's not as such like, okay, mental and behavioral disorders, but one category that has been made.
It is not
So
that
if you
it is
want,
not under the purview of mental health, and so we can still go ahead and diagnose tics, Tourette's, land of Kleffner syndrome, epilepsy. As if we are able to do that, we can do that. It's as simple as that. We can use all ICD-11 from chapter 1 to chapter 26. We can use because we are professionals, medical professionals. But these disorders are classified elsewhere to make a uniformity that these are sexual health related disorders. That's it. And sleep and wake disorders. That's it. So they have that mind body classification or organic non-organic classification has to be removed. That is why they are put in the separate group, because earlier non-organic things were kept in mental health related problems and organic things were kept in genitourinary. Such artificial distinction is not mandatory anymore. So they have kept everything. Doesn't mean that psychiatrist has not been doing a proper job in treating sleep disorder or sexual disorder, or only urologist or the genitourinary specialist should treat it. Nothing like that. We can still go ahead and diagnose as long as the person meets the definitive criteria. We can diagnose and continue treating that individual.
I think one important thing to note here is the in the context of this question that other specialties are taking up this. So if you want psychiatrists to be to keep hold of these disorders, you have to publish more papers in it. You have to make guidelines, white papers, talk to lay open media, press media. So if you are working on it, if you are talking about it, then ultimately it goes back into your fold, because many specialties are nibbling on our core things. So I think it is the onus is on us. So how we can keep the things with us. I hope I think you all would agree with that.
Yes, sir. Because
So there's a question after.
yes, sir.
Yeah, please.
I think,
Please
sir,
carry on, Ravindra.
a common thing is like people have a myth that sexual dysfunction and sexually transmitted diseases are the commonly mistaken. So invariably, most of the people will end up with dermatologists. So dermatologists will claim that, okay, they are the one who are going to teach sexual dysfunction. So that thing has to be, corrected. Yes, sir. Yes.
Okay. So there's a question. After 6A, there is 6A0, there is 6A2. Why 6A1, 3, 5, 6, 3, 5, and 9 are missed? Any specific reason?
So it is to accommodate future disorders. It's like simply missing channels in DTH. So you will have certain empty spaces to include HD channels. So similarly, such say for example, between 6A2 schizophrenia spectrum and 6A4 catatonia, 6A3 will be missing just to include in future if there are expandable ways in which psychotic spectrum can be made little bigger. Only to accommodate that such skip has been, but most other places there will not be such skips.
Okay. There is I think a request. Please post ICD-11 Excel format for the benefit of practicing psychiatrists. I think he means to compare the ICD-10 and 11 disorders.
Okay.
Sir, one thing that they can do is I have posted the link of ICD-11 website, which is an online tool where you can just type a diagnosis and it will give where it falls as a diagnostic under category. And the website gives the white papers where all the revisions are suggested, how they are adopted, ICD 10 to 11. So all those details will be available on the websites. So they can explore those websites. And also I have shared the GCPN link. If somebody is interested, they can undergo the training online. So it's quite comprehensive, and they have good modules for training.
I think that is a very useful thing. Thank you, Ravindra. There is a question: neurasthenia, psychalgia. How to code these things?
So they will now be coded under bodily distress. So see, and here as well, the cultural aspect has been kept very intact, because in our country, people would say that they have some gas-related symptoms, or they feel there is some tingling in their brain, or they will say that their nerves are weak. They could sense that their nerves are weak. All these symptoms are now classified under bodily distress, culturally specific to that country. So that so different things that were there as somatoform, undifferentiated somatoform, somatization, neurasthenia, all these have been included under the single category called as bodily distress disorder.
Okay. So one person wants to ask the reason for increasing developmental age from 18 to 22.
Yeah, shall I take that question?
Yeah.
Yeah, what happened was like even the voting age, etc., is 18 years, right? But anatomically, physiologically, and everything, all the research have mentioned that the whatever synaptic plasticity pruning that is happening, it continues actually till the age of 22 or till 25 also. Many of the disorders will evolve during that time. So that's the reason that age has been increased up to 22. Okay, so this is available in one of the research papers, why there was a debate on that, increasing the age group, etc. Okay, so that's one more reason, like starting substance use early is going to lead more problems when there is a synaptic pruning is happening at that time, which disrupt the process, substance use. Okay, so that is one of the reason.
Okay. Dr. Anand wants to ask which all state governments have implemented ICD-11 in departments? Which institutes are doing it?
In institute-wise, I can answer for NIMANS. In NIMANS, addiction medicine is using ICD-11. Psychiatry is transitioning between ICD-10 and 11. But as on Jan 1, 2022, the WHO states that ICD-11 has to be implemented. And India is one of the partnering signed countries of 190 countries that are part of UN Health Assembly. So we should also try to move on soon to ICD-11.
Yes, sir. What we did in KMC Manipal, once the government notification come, for 6 months we had a discussion during chart meeting, etc., about ICD-10 and ICD-11. We are training and discussing in both. So Jan 2023 onwards, we shifted completely to ICD-11. So it's been more than a year now. It's 1.5 years that we have moved to ICD-11 completely at KMC Manipal now. Okay.
So you are the pioneer in the field.
Yeah, that's probably. That's why the format of workshop, etc., that we have developed, you will be surprised to know. GCPN is doing training. Apart from that, we are the only people who are doing hands-on workshop for ICD-11 across the globe. We didn't come across anybody training people in ICD-11. So, and I hope CIP Ranchi has also a transition to ICD-11. That's what I heard when I met last with Dr. Nishantan.
Okay. Okay. So what is the new terminology for gender dysphoria and ego dystonic sexual orientation in ICD-11?
So gender dysphoria is retained the same term, gender dysphoria. So they wanted to take out gender dysphoria completely out of ICD-11. They didn't want to include it even under sexual health problems. But in certain countries, it is needed for diagnosing individual for either surgery or for them to get disability benefits. Only for that purpose, gender dysphoria is retained in ICD-11 and it is under sexual health chapter 11. Sexual orientation related things are taken out, I believe. It's not part of ICD-11 in it.
There is a term, gender incongruence is also used, which is a matching term with gender dysphoria, because at time they felt, let's say previously gender identity disorder, which was more derogatory and we are stigmatizing, then gender dysphoria came. Now gender incongruence is being pushed into as a term for these entities.
Okay, sir, what are the disadvantages of ICD-11? Someone has asked.
So since we have not gone into critically evaluating ICD-11, I was not covering it. But the number of disorders have increased. So that is usually seen as a disadvantage. I mean, say for example, prolonged grief disorder has is seen as a significant disadvantage because earlier it was a part of adjustment. Now it has become a disorder. So such inclusions, including body integrity dysphoria, these things are seen as disadvantage, and it is left to the flexibility is given more to the clinician. So the uniformity of it may be questioned, and it is not actually moved towards dimensional nature, and it still retains many categorical things. Say, for example, 5 symptoms should be there in depression to be coded. At least 2 weeks is given. So there are multiple other disadvantages, but more number of disorders and more complex coding are seen as disadvantages, but it gives flexibility, and it also assumes that all psychiatrists will ensure that they are reasoning in the same way. But that is where the field is having a lot of problem, which is inter-rater reliability. So if I am diagnosing using the flexibility given by ICD-11, will another psychiatrist use also say diagnose in a similar way? If you take the new disorders that are added in ICD-11 out, the inter-rater reliability is poorer than ICD-10 is the field trial report.
Okay, okay. There is a question. ICD-11 is CDDR diagnostic requirement. So doesn't requirement mean threshold here? I'm not sure what the question means.
Here earlier it was guidelines, diagnostic guidelines, but right now in this book, it is very clearly says that there are certain essential features which has to be there for that disorder to be diagnosed, and hence it is called requirement. But within that, it has given a lot of flexibility by not focusing on the number of symptoms or the number of months or weeks which the symptom has to be present. So it is a requirement in that sense that the essential features have to be met for a particular syndrome to be diagnosed.
So there is one more question. Would like to take it up about where somebody has asked, what are these blocks, etc. in ICD-11. So actually, if you look at the ICD-11 structure, it has chapters and blocks.
Yeah.
There are 26 chapters and there are blocks. In the 26 chapters, chapter 6, 7, 8, and 17, these are the ones which are concerned to us.
Yes.
6 is MBN, mental behavioral neurodevelopmental disorder. 7 is sleep-wake disorders. 8 is nervous system. 17 is related to sexual health. So these are 4 chapters which are related to psychiatry.
Yeah.
In these chapters, there are sub-blocks. Let's say MBN. Chapter 6 has A block, B block, C block, D block, E block, like that. A will deal with neurodevelopmental schizophrenia, B will deal with anxiety. So these blocks are nothing but the group of disorders under each chapter. So this is the basic construct or outline of ICD-11. From there, we can move on to what Dr. Dinakaran sir has mentioned about essential criteria, etc. will come next. Okay, chapters, blocks, then criteria in individual disorders. So I hope that is clear. Somebody has put that question in the chat box. Thank you, sir.
And from the block, the I and O has not been included because of there is misleading from 1 and 0. That's why it has been alphabet O and I has been removed. Yes.
Yeah, this has come up in one of the discussions in our workshop. Why those are not there? Okay, this
Yes.
was the reason, because there is going to be confusion.
Yeah.
Yes. Yes.
Okay.
I just wanted to add, though it's been almost 2 years, this has come, there's not much enthusiasm in psychiatry community about this.
We never followed
Exactly.
ICD-10.
At least
It
in the
is.
teaching institute, it is a craze now, sir, because the transition has to happen. And if you look at MHCA, they warrant that they demand that latest version of ICD as recommended by WHO has to be used for diagnosing or for all the legal purposes. At least if somebody finds a case like you are not using the latest version of diagnosing, so that will become a problem. So sooner we transit to ICD-11, this will be better for everyone.
I'm thinking IPS and IAPT would have at least held around 100 plus conferences in the last 2 years plus. And I don't think so ICD-11 is done anywhere. So this is very interesting.
We are doing
Is it because they have taken so much away from us in ICD from ICD-10? They've taken so much away from psychiatrists. They've taken sleep disorder, sexual disorders. They've taken away, schizophrenia. They've stopped the categorization. Is that the reason? I mean, like passive aggressive behavior. We are behaving as like we're not happy with ICD-11. This is what I'm getting sense I'm getting out of this.
No, sir, as such, because if you start using it, you'll find it is quite user friendly, and it helps you. It will help you in diagnosing, and it will help you like even the unexplored thing or unexplained thing where we had some categories, some queries in ICD-10, we didn't know where to put. Now we can put. As of schizophrenia mentioned, we have one diagnosis, but we have specifiers, positive symptoms or negative symptoms or cognitive. Okay, so that is useful. The reason for removing many of the categories is invariably we'll have paranoid schizophrenia and other things are very rarely. But all those things requirement was earlier the person had delusions or FRS. And another change here is they have de-emphasized completely FRS. First line symptoms have been de-emphasized in ICD-11. Again, we are going back to Doylerian concept of schizophrenia here. Okay, so this is some wonderful thing that is happening, transition that is happening. It will be interesting once you start using it and looking at from that perspective.
Yeah, maybe I think IPS needs to have a conference on ICD only. And we don't have a task force. I mean, people also, Nikhil is also right now. Nikhil is writing. Yeah. We have so many subcommittees, but not a single subcommittee on transitioning from ICD-10 to ICD-11.
Alim
sir,
Yes,
Alim sir.
That point is noted. We'll discuss it.
Yes.
There is another question. Can you elaborate on the advantage of using terms secondary disorders? Example, secondary mania in place of organic disorder, that is organic mania. What is the advantage of?
Indirectly by organic, we are meaning that something else is causing this disorder. No? So it is better to call it secondary. And in ICD-11, the secondary disorders are categorized in a very clear way. And they have been given multiple examples. Say, for example, it's a secondary mood syndrome. What are the possible neurological, endocrinological, metabolic, or infectious diseases that can lead on to a person having mood disorder? So that is very clearly given, which would help people to understand that. So this dichotomy of organic, non-organic can be taken out, and we can say that this mood disorder has happened because of hypothyroidism. So you will code both hypothyroidism as well as a depressive episode, saying that it is secondary to hypothyroidism. Say it is secondary to anemia. Such things is very clear that it need not be called organic. It is secondary to a medical condition. So that is the advantage of doing it.
So Dr. Parag wants to ask, ICD-11 is now more aligned with DSM or less?
Much more aligned. They're all speaking the same tone now. I mean, if you see the DSM-5, people who have gone through DSM-5 would appreciate that ICD-11 structure about essential features, core specifiers, culture-related symptoms, development-related features are all aligning along with the DSM-5 actually. And the grouping is also in a lifespan approach, from intellectual disability to neurocognitive disorder. So it is almost speaking the same tongue. Both are speaking the same tongue.
So Dr. Aarti wants to ask, are these changes in other disorders or only so much changes are there in psychiatric disorders?
Okay. Yeah. So there are few other categories added as well in blood and blood-borne disorders and immune-related disorders. Of course, there are changes. So that's why DSM is only mental health-related classificatory system, whereas ICD takes care of all systems, all types of disorder, from infection, neoplasm to circulation, respiratory, everything. So they update based on the differences that happens in the field of science over 25-30 years. So they all are updated as well. but not very much changes as you see the transition that has happened with mental and behavioral disorder.
Thank you. I think we have covered all the questions.
Hmm.
Vishal bhai, anything is left? It was a really wonderful presentation. We were wanting to have some sort of this earlier also, but we could not finalize it.
So
We had
one question is there, boss. Dr. Shalini Anand question.
which
She just messaged. Let me check on the chat. Can you
I think
type?
all in all. Pardon. Yeah, please, Vishal.
Sorry. There's some doctor. Dr. Shalini, can you put your question
Disadvantage of
again?
ICD-11. She
How is it
asked,
to differentiate between CPTSD versus BPD?
I think that is not a part of this presentation. It is a different question. Complex
Okay.
PTSD. He wants to
Okay.
ask complex
Yeah.
PTSD and BPD.
So I can give an answer quickly. So borderline personality disorder and CPTSD. So complex PTSD, it is very clear that the trauma should be prolonged and repetitive, like in domestic violence or repeated child sex abuse. So that is a very clear diagnostic need to diagnose somebody as CPTSD. And if you have to diagnose somebody as complex PTSD, they should definitely have simple PTSD, or they should have those three symptoms like re-experiencing, avoidance, and hyperarousal. Along with that, they should have negative views about self, affect regulation problems, as well as they have difficulty maintaining relationships. So this difficulty maintaining relationships can be similar in borderline personality and CPTSD, but there in borderline, the problem is fear of abandonment, that the person would leave them will be the fear. But in CPTSD, the problem is because of the fear that if they get into this relationship, will this be a trauma again? So that avoidance is the feature in CPTSD, whereas fear of abandonment is seen in borderline. And impulsivity is very common in borderline trait personality disorder, which is not a feature in CPTSD. Here, people can have suicidal attempts in both complex as well as borderline. But in borderline, the intentionality or the lethality will be very minimal. In complex PTSD, the number of attempts may be very minimal, but the suicidal attempts will be very, very severe, and people may lose life in complex PTSD. But the clear feature is in borderline personality, the re-experiencing, avoidance, or the hyperarousal startled responses will not be there. But in complex PTSD, these will be there, and the trauma that is contributing would have been persistent or repetitive.
Yeah, just add to add. So the advantage of ICD-11 is it mentions boundaries with normality, boundaries with other disorders. So
Yeah.
once you go to the website and just check, so all the differential diagnosis that we discussed based on the evidence, everything has been mentioned there.
Yeah.
A clear-cut segregation, like how we can differentiate from it.
Yeah.
That's one good thing with the ICD-11.
Thank you. I think we have now covered all the questions. Dr. Vishal, can we wind up? Because already it is 9:30, past 9:30.
yes.
Dinakaran has been speaking non-stop. Wonderful presentation. I think we go to Tufan sir for the final comments and thanks. Sir, you have to say the thanks also. Tufan sir.
Thank you, Dr. Dinakaran, for a elaborate presentation, enlightening, and Dr. Jitendra and Dr. Munoli
Thank you, sir.
assisting a lot. And as it was raised by Dr. Chavra, Vishal Chavra, that as and today, to my experience, people are less following ICD-10. If you go to the real diagnostic slips, which circulates in the community by practitioners who are 30, 40, 50 years in practice, they have not been able to accept ICD-10 adequately. It is mostly related to the ICD-10 as of now, to the medical institutes. Although it is categorical in Odisha government, because I have gone to many hospitals, they go, there what code will write here? We have treated, cured. Code क्या कर रहा है? ये code क्या है? So I think I should transition from again to ICD-11 will need some intense training. It has to be intense and deep-rooted. And as it has been raised, we had a seminar on nosology in ANSYS 23, but necessarily not focusing on ICD-11, because then it was very much young to be taken. Nosology, it had, I don't remember for the transactions, but it might have come or not. But this was up to the faculties. But at all level, Alim can take care, state level, basic levels, if we have a training program or awareness raising that advantage of ICD-11, vis-a-vis disadvantages, I think the take-up will be better, at least know what are the problems. We are know that till now we know the advantages as proposed by the proponents. There could be some opponents. How much did it take to from 10 to become 11? Very few years. Maybe we are awaiting 12 also. Thank you very much, Dr. Vinakaran, Dr. Monoli, and Dr. Jitendra, Dr. Alim Siddiqui, and Dr.
Thank you, sir.
Vishal
Thank you.
Chabra. Vishal Chabra. I am also
Thank you,
thankful
sir.
to Tarrant for sponsoring this program. And on behalf of IPS Odisha State Branch, I propose a sincere, hearty vote of thanks to you all, as well as all the participants over today. Thank you.
Thank
We
you,
are
sir.
6 set
Thank
of double
you.
century. We are just 6 set of double century. Alim,
Yes,
right?
sir. Yes, sir. Yes, sir. Yeah.
One
100,
six,
100 होने वाले हैं. Sorry, Singh.
one,
Yeah.
one
Thank you,
sixer,
thank-
one sixer double century.
Yeah,
Yeah.
62%.
Thank you, sir. Thank you, sir. I think when one of two of our colleagues get caught in the legal tangle of not using ICD-11, then everyone will panic and start. So before such things arise, kindly consider that it is a legal requirement also at some point of time. So you have to be updated because for this thing before damage is done, get trained in it. So
Before you
contact
come,
Dr.
there is
Vinakaran for
there is another legality. There are many cases, but the cases in India which are pending in different courts of law is astounding. Some cases were filed with ICD-9 in practice. When they have crossed to institutes like NIMANS or CIP, that level is there. These transitions have not been able to impact those papers, and the person who had given that diagnosis, he cannot be held at fault. He has given in 1980s. What job he has got to come here? It is so it is awareness of everyone, the legal persons as well as the executive. There are signs changes like this. If you are insistent about this diagnostic system, you spread the news along everyone. I can quote many papers. I had to appear for a long case where it was receiving long ago. It is a process schizophrenia. What will do? But that continues. The person who had given quite senior to me, he was never wrong in that. And cases linger. This is another aspect of legality which has to be taken into consideration, and they have to come to the notice of the authority that they have to be prepared for that. You cannot just prosecute a person who has written 2 years ago on ICD-9, ICD-10. Okay, and everything is up to the people who pioneerize. Dr. Dinakaran remains. You must think over it and suggest the government, but we are there to accept it. If you, okay, thanks everybody again.
Thanks. Thank you so much.
Thank you, sir. Thank you, everyone.